and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I am your host, Rebecca Sack. I am a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy will focus on the topic of Mast Cell Activation Syndrome, which is a topic of interest to many of us as it seems to be more and more in the lay literature and referrals coming in. We are pleased to welcome Dr. Onyinye Iweala. Dr. Iweala is an assistant professor of medicine at University of North Carolina School of Medicine. She is the director of the Allergy, Mast Cell Disorders program, and her primary research interests include the pathogenesis of alpha-gal allergy and the regulation of IgE antibody responses. So pretty much everything that activates mast cells. Dr. Iweala, thank you so much for taking the time to join us today.
I'm very excited to be on the podcast. Thanks so much for inviting me.
Oh, and thank you so much for doing this. This is a topic of great interest to so many of us. We get lots and lots of questions, and so I'm excited for you to teach us more.
All right. So I guess, we can get started.
So the first thing I like to do is just get to know our guests a little bit better. Can you just give us a little bit about yourself and then tell us something you like to do outside of medicine?
Awesome. Okay. So as you said, my name's Onyinye Iweala. I'm an assistant professor here at UNC, and I'm part of the Food Allergy Initiative at UNC. I am Nigerian by heritage, but I was born in the United Kingdom, so a lot of international flavor. But I basically grew up in the United States in Maryland, right outside of Washington, D.C. I fell in love with immunology when I was a junior in college. I just, for whatever reason, I loved the complexity, and it was the first time I could see like a direct connection between basic biology and human health. So I got drawn in, and I got drawn into lab science as well. And so kind of going down that pathway, learning more about immunology and immunology in the gut. When I was looking for specialties as an intern at Mass General Hospital, I was like, and I had the great fortune to actually rotate in your clinic and just see how fantastic allergist immunologists were and the types of patients that allergist immunologists were taking care of. When I rotated through the MGH allergy immunology clinic, I was like, these are my people, these are my patients. And that solidified for me that I wanted to apply. It took me a little while to come to terms. And so I applied a little bit later. So I ended up taking 1 year between, a year and a half actually, between graduating from residency, which I did in 2013 from MGH, and then starting fellowship at UNC. So I worked as a hospitalist at the Durham VA Medical Center in Durham, North Carolina. And we had moved down here for jobs because my husband also is a physician and had gotten a job here. And so, I worked as a hospitalist for about a year and a half, then matched an allergy immunology fellowship at UNC. And then since then, like you said, I've primarily been focusing on research in alpha-gal syndrome, but I have this interest in the alpha-gal syndrome mast cell activation overlap that we can see in some of the patients that we take care of here. And then I'm interested in why mast cells would activate for whatever reason. So that's why, from a clinical standpoint, my clinical practice is really veered towards treating patients with MCAS, with clonal mast cell disorders, and those patients who think they may have MCAS or who have symptoms of mast cell activation. I think, and then I, have other hats. I have my family, of course, 3 kids, and I think that's pretty much me.
It sounds very busy. Keeping up with
There's
everything.
There's a lot going on.
Perfect. So mast cell activation syndrome, I think one of the biggest conundrums is how do we diagnose it? What is the definition of it? And then how do we really make sure that that's what patients have? Maybe you could go over that with us. That'd be great.
Excellent question. So I always say this especially if I'm giving talks to other specialists or to primary care providers, that I say to them, what do allergist immunologists mean by MCAS or confirmed mast cell activation syndrome? And so I follow the QuadAI 2019 guidelines that were published by the Mast Cell Disorders Working Group. And so in those guidelines, they outline very clearly there are 3 criteria that we look for when we're going to diagnose a patient with confirmed mast cell activation syndrome. And so the first is that they have quote unquote typical symptoms. And so by typical symptoms, we mean episodic symptoms that would be consistent with mast cell mediator release involving the skin, gut, cardiovascular, airway. And you want 2 out of those 4 organ systems. And I think the key point here is that it really has to be symptoms symptoms we would expect to see in an immediate hypersensitivity response, like what we would see with a food allergy or a drug allergy. So I take a lot of time to explain to patients that if you've got a rash that's lasting for 4 weeks, that is not going to be driven by that's not the skin symptoms we're looking for mast cell activation syndrome. Or if you have petechiae across your abdomen, yes, you have those, but those aren't the symptoms that we're looking for skin symptoms for mast cell activation syndrome. Similarly, for the gut, many patients will come in and say, "Oh, I have fluctuation between constipation, diarrhea, but I'm mainly constipated. Is that my mast cell?" And I'll say, with the gut symptoms, we're looking for it's what you're looking for is like a danger response of the mast cells. Like they're trying to get things out. And so the kinds of GI symptoms we're going to be looking for are diarrhea, vomiting alongside the crampy abdominal pain because it's trying to get things out. So I try to emphasize what type of skin and gut symptoms we're looking for. But that would be the first criteria. So having those symptoms in two or more out of those four organ systems. And the idea is you can have episodic symptoms, or you may have episodic symptoms involving those two, and they may be superimposed on more chronic symptoms that you have daily. So then the second criteria is that when you take medications that are targeted against mast cell chemicals or mediators or supposed to stabilize the mast cells, that you feel better. I recognize like you're not going to get cured. We don't have a cure, but that you notice a difference on the medicine and off. And so those will be the over-the-counter antihistamines, and then the prescription mast cell stabilizers like cromolyn, ketotifen, or even the leukotriene receptor blocker family. Like if we can get any sign of improvement with those medications, that's the second criteria. And then the third criteria, and this is the one that's usually the hardest to fulfill, is that you have to have lab tests that are consistent with mast cells gone wild, is how I like to describe it. And so I always say that our gold standard is the tryptase. And so we're looking for elevated tryptase levels at baseline. And there are two different categories. So if your tryptase is 20 nanogram per mil or higher, then we're more worried about a clonal mast cell disorder, like our pretest probability and suspicion for that goes up. If it's 8 nanogram per mil or higher, then we're thinking about these hereditary alpha-tryptasemia. So this genetic trait that seems to increase the risk of spontaneous anaphylaxis, and you can see it in both non-clonal and clonal mast cell disorders. So because most of the time it's really challenging to actually get that tryptase, there's another way to look at it, and that is get the tryptase at baseline, it may be normal, and then get it again within 4 hours of having a flare of the symptoms that the person thinks are mast cell activation. And if it increases by a certain amount, and it's like 1.2 times the baseline plus 2 nanogram per ml, or there's this really cool NIH tryptase calculator that I like to use, where you can just put in the baseline, put in the increase, put in your pretests, your suspicion about whether you think this is really mast activation syndrome, and it will just calculate the ratio for you and tell you whether or not your patient fulfills that. I think that's an awesome tool, so I use that. So that's another way we use tryptase. And then finally, we also can do 24-hour urine testing, which is still an annoying kind of test to do, but is usually more feasible than having the patient run to the ED or urgent care to get their blood drawn. And so there, we're looking for the breakdown products of mast cell mediators. So N-methylhistamine, prostaglandin metabolites, leukotriene metabolites. And I believe at the Mayo Clinic, they also have a program where you can actually you can also collect your urine 4 hours after symptom flare, and they look for those same types of mediators. So long answer to say, we need to have those three criteria for us to say you have confirmed mast cell activation syndrome.
Does the 24-hour urine versus kind of a spot check of the urinary mediators, is that a reasonable to just do a spot check, or you really need that 24-hour collection?
Yeah, also great question. So in our program, we tend to do the 24-hour collection because that's what we're used to. But at a recent talk, I think a couple of years ago at Quad AI, the experts at the Mayo Clinic have found that the 4-hour spot urine check, like if you get it within that 4-hour window, that it should be equivalent to doing the 24-hour in terms of seeing the elevation. But we haven't adopted that yet. I think it requires a little bit more logistically in terms of to get the patient there and send the samples appropriately. So we've been sticking with the 24-hour urine collection.
We have too, but I had read the same paper that said that maybe the spot would be useful and much easier for patients. And then
Exactly.
Are there any medications that patients have to hold during that time?
Yes, that's a good point. So, medications that can impact things like prostaglandin, basically prostaglandin release. So NSAIDs are the big one, basically, because they can alter basically whatever the concentration of prostaglandin metabolites are that we actually collect. So I believe it's within 72 hours. I can't remember the amount of time that we tell people to hold. I believe it's about that. But yes, you're right. You do have to counsel patients to be wary and be not using those medications when they're doing that collection.
Is there any link between hereditary alpha-tryptasemia and mast cell disorders?
Okay. So, yes, I think this is a good question to have a discussion about. So, so far, I think what everybody in the field seems to agree on is that having the hereditary alpha tryptasemia trait, so this increased copy number that increases the number of alpha tryptase that you produce and have in circulation, that seems to be a risk factor to increase, your risk for spontaneous anaphylaxis, whether you have a non-clonal mast cell disorder or you have a clonal mast cell disorder. I think that's one thing everyone agrees on. From my perspective, I actually think that so hereditary alpha tryptasemia is not a mast cell disorder. It's a genetic trait and it influences the risk of anaphylaxis whether you have clonal or non-clonal mast cell disorders. When it was first described, it was described sort of as something that was associated with these non-clonal mast cell disorders, but I think a lot of additional research looking at a broad spectrum of patients in different populations have pushed people towards this other understanding of what HAT is as a risk factor for anaphylaxis. So I think that's the party line right now. But I wonder.
Yeah, but there is this kind of, even the papers put out by Dr. Lyons at the NIH list a
Yeah.
lot of these symptoms that are similar to mast cell disorders that they
Yes.
see an increased rate in hereditary alpha tryptasemia. So it makes you wonder.
It makes me wonder a lot, especially because that's how it was initially described. Like Dr. Lyons' paper from 2016 in Nature Genetics really described a constellation of symptoms that you see in a lot of people that come in with symptoms of mast activation or confirmed MCAS that's not clonal. So I still wonder about it, but as you're reading the literature, there's still this controversy about it. And I think the one thing we can agree on is that it definitely increases risk for an idiopathic anaphylaxis.
And is chronic idiopathic urticaria, is that a mast cell disorder?
Great question too. So I think about mast cell disorders, like systemic mast cell disorders, as being on a spectrum with chronic spontaneous or autoimmune urticaria and angioedema. Because I think about that as, yes, it's driven by mast cells and basophils, but I really think of that as localized mast cell activation. So whereas I think about symptoms of mast activation, confirmed MCAS as being a systemic disorder that requires, at least two organ systems, I think of chronic idiopathic urticaria as being driven by mast cells. It's just localized mast cell activation. But I do try to distinguish because I do have patients come in saying like, I have mast cell activation syndrome. And when I dig into their history, it's really, yeah, I break out in hives all the time. I have swelling, but there are no other organ systems that are, involved at the same time or episodically. So I'm like, no, you really have spontaneous urticaria angioedema.
And then who should we suspect of a mast cell disorder? Are there certain associated diseases? Are there certain risk factors that we should be on the lookout for?
Yeah, so I think if someone's coming in with a lot of history of idiopathic anaphylaxis, so they, for whatever reason, they couldn't explain what was going on, but they had this random episode of a severe hypersensitivity response and they couldn't identify a trigger, that's a person that you should be thinking about a mast cell disorder. Individuals who have really severe responses to insect stings, so stinging insects, venom, allergy, we always want to think about checking tryptase levels in those patients because there's a higher risk of clonal mast cell disorders, especially if people have syncope as well as, multi-system and syncope. That definitely something where you're like, whoa, something else is going on. And then another situation is with alpha-gal syndrome. So that's that red meat or mammal meat allergy that's associated with tick bite. There was a great study out of the NIH where they showed that those patients that seem to have really severe hypersensitivity responses with syncopal episodes after eating mammalian meat and having alpha-gal syndrome, they also had higher rates of having elevated tryptase and clonal mast cell disorders. It was a small study, but there was that signal there. So I think when people are having these really like severe anaphylaxis, your suspicion should go up that there may be a mast cell disorder lurking.
And then there's become this controversy about mast cell disorders in conjunction with Ehlers-Danlos and then also dysautonomia. How did that come to be, and how should we think about that?
All right. So, I mean, maybe what I'll say is a little bit controversial, but I think that this came to be because there are a large number of patients who have joint hypermobility or Ehlers-Danlos syndrome, who have dysautonomia, who are also presenting with symptoms of mast cell activation. So some patients are coming in and it's primarily hives. They're describing chronic urticarian angioedema. But I do have fairly large subset of patients who don't just have localized mast activation in the skin, but are describing diarrhea alongside the hives, or they're describing a throat tightening sensation alongside with diarrhea. So they're describing symptoms that could be caused by mast cell mediator release. And so I think, and again, my thought is that people who have dysautonomia can also have symptoms that could be considered mast activation type symptoms. And the biggest one is the flushing. So patients with dysautonomia can have flushing because the autonomic nervous system regulates the tone of the blood vessels. And so, but people who have mast cell activation can also have flushing because you can have that usually in conjunction with pruritus. It's almost like a precursor to like the hives, like on the surface of the skin. And so you have patients with those types of symptoms coming in and wondering, is this mast activation driving this, or is this my like a flare of dysautonomia? The other issue is that the enteric nervous system which is the nervous system that's part of the gut, is also part of that autonomic nervous system. And so you can have functional diarrhea syndromes where basically the nerves and the gut musculature aren't communicating appropriately with each other, resulting in things like diarrhea and then constipation and so forth. And so again, there's a differential diagnosis for this symptom that could include mast activation, and so I think that's why it pops up on people's lists. That being said, though, I really think that if you have nerves that are sort of messed up or twitchy, like what you see in dysautonomia, and if you look in any cross section of tissue, nerve fibers, mast cells, and blood vessels are all in close communication with each other. And there's been some fantastic basic science work with mouse models showing that mast cells and nerves can communicate with each other. So my bias is that mast cells are immune cells that are supposed to respond to danger signals, whether it's external dangers, like pathogens or toxins or venom or mistaken dangers like food allergens, environmental allergens, or if it's internal danger, so like autoimmunity or autoinflammatory situations or messed up nerve signaling and dysautonomia. And so they can respond to neuropeptides and neurotransmitters. I think that lowers their threshold for degranulation and you start to get these symptoms of mass activation. So sorry again for being so long-winded, but I think that's part of it. And then when it comes to the joint hypermobility stuff, so if you think about how mast cells mature, they basically mast cell precursors arise from the bone marrow, they enter the circulation, and then they have to go to tissues, right, in order for them to actually become mature mast cells. And they depend on signals from their microenvironment to know what to do. And so again, this is my bias. I have no no data for this, but my thought is our whole body depends on connective tissue or collagen scaffolding. So if you have a patient who has a joint hypermobility syndrome, sure, it's obvious that you can see like, okay, their joints are different, their skin might be a little bit stretchy, but across the body, it means that their collagen is different. So to me, that means that the mast cells that are migrating there may not be getting the same types of signals that they might expect. And maybe that's another reason why their threshold to go crazy is lower, and maybe that could be one predisposing factor.
No, that makes sense. So in these patients, what are the triggers we should watch out for? So let's say we have a patient who we're working up, or maybe they've been diagnosed, they have elevated mediators, or they have an elevated tryptase that's kind of low level elevation. What are the triggers that we should tell them, watch out for these things?
Yeah, great question. So, there was a really nice paper in Jackie from the Mast Cell Disorder Society in 2014, where they actually took patients with both clonal and non-clonal mast cell disorders and asked them what are their top like 8 triggers. And so I think the top ones were heat. Like heat is a big one. So I think dramatic shifts in temperature seem to be a trigger for patients with clonal and non-clonal mast cell disorders. Stress, I mean, is also a huge trigger as well. And to me, that makes sense because even if we're thinking about people with chronic hives and swelling, I'm frequently counseling patients that stress can be a trigger for them to spontaneously break out in hives. And people tell me that too. They're like, oh, it was really stressful. Like all this stuff was going on. And I just broke out in hives or I started swelling. So that's also a trigger for patients with the systemic mast cell activation syndromes as well. And then exercise can be one as well. And then the other thing I would point out is it's possible for people to have mixed disorders. So meaning you can have the spontaneous mast cell activation alongside of an IgE triggered mast cell activation. So patients could have food allergy or environmental allergies, and this could then set off the more systemic symptoms too.
Yeah, no, absolutely. And then, so how do we treat these patients? How do we get them feeling better?
I know this is like the biggest thing. So I think the vast majority of patients are going to get some relief of symptoms with over-the-counter antihistamines. So,
Mhm.
and this is another reason why I sort of think of this on the spectrum of chronic hives and swelling, because what's the first thing we tell people with chronic hives and swelling to do? Take some, over-the-counter antihistamines. You can go up to as high as 4 times the over-the-counter dose. And so I use that same principle, whether or not H2 antihistamines like famotidine are as helpful in chronic urticaria, unclear. Some people feel like it may work synergistically. In more of the systemic mast cell activation patients, whether they're confirmed or whether they're biomarker negative, if patients are dealing with a lot of gastrointestinal symptoms, so the diarrhea and the vomiting type of situation, the H2 antihistamine can sometimes be very helpful in that context. So I have a low threshold to add those on as well. And then after that, I'm going for prescription mast cell stabilizers. And so in the United States, it's cromolyn sodium. That's the one that's the most widely available. And the thing about cromolyn is to remember that it works where it touches, like it works where you put it. The systemic absorption of cromolyn is pretty low. And so what I'll do most commonly for people with a lot of GI symptoms and abdominal cramping is prescribe oral cromolyn. And then if they are having a lot of issues with throat tightening sensation or wheezing that doesn't really respond as well to inhaled corticosteroids and long-acting beta agonists, I'll prescribe them nebulized cromolyn. So you can actually use nebulized cromolyn for patients who feel like they're dealing with a lot of itching, hives, that type sensation. I even, I learned from patients that you can actually take cromolyn, you can mix it with a moisturizer that they feel comfortable with, and you can actually rub it on the skin. You can actually prescribe compounded cromolyn cream as well, and that can provide some temporary relief, like anywhere from 2 to 4 hours for the itching sensation that people will report. So
Wow.
yeah, it's not. So after that, you can also, so it's kind of like a ladder. So we talked about antihistamines, we've talked about both H1, H2, the mast cell stabilizers. So leukotriene receptor antagonists, or basically medications in the leukotriene pathway, can also be useful. Now, I recognize there's a black box warning on things like Montelukast, and I don't know if this is the correct statistic, but I was always taught 1 out of every 10 people can have an issue with mood or vivid dreams taking medications like Montelukast. So I always, provide that counseling. But for patients that are dealing with, a lot of itching that isn't 100% under control with the antihistamines, if they're dealing with a lot of congestion or respiratory type symptoms, I actually find that the leukotriene receptor antagonist can be useful in that setting. So I'll turn to those as well. And then, if we're working up this pathway, there's also room for natural supplements as well. So with this, I always have to say there are no randomized controlled trials that demonstrate that any natural supplement is effective for the treatment of symptoms of mast activation. So this is all from anecdote and clinical experience. And there's a little bit of in vitro data that seems to suggest that things like quercetin and vitamin C can act as mast cell stabilizers. So if patients can tolerate that, I haven't really seen any harm from taking those medications. And for some patients, actually a lot of patients, quercetin and vitamin C can have a lot of benefit. So I think it's worth describing, or mentioning that that could be a possibility. And then completely off label, you if when you're kind of when you've gone through all these other things all the way through the different natural supplements, I start looking at immune modulators. So most commonly, people are getting things like oral steroids, prednisone, not for long-term treatment, but to treat bad flares. So people will be on either short-term bursts, medium-term, like 2.5 week tapers, or I tend to favor 8 week long tapers if the patient is really describing multiple flares, multiple use of their epinephrine autoinjectors. But then if that's going on, then I'm really thinking we need a steroid sparing immune modulator on board. The most common one I'm going to turn to is going to be omalizumab. And that's just because the vast majority of these patients will have hives and swelling in the context of their larger disease. And so I have a justification to prescribe the medication, or they may be dealing with asthma type symptoms. And so I have a justification there. And now that dupilumab has been approved, like just in April, that's
Yeah,
a new option that I'm thinking about. I haven't yet used it as widely, but now I'm like, oh, for those patients that don't tolerate Xolair, if it's not approved for whatever reason, the omalizumab, then now we have something else we can look at. So beyond that, I start turning towards like the management of hives and swelling that's not responsive to our FDA approved biologics. And so that's, going towards things like the cyclosporins, hydroxychloroquine, methotrexate, tacrolimus. So, a little bit more rheumatology like medications. But with hydroxychloroquine, we actually get pretty reasonable results here at UNC, whether it's hives and swelling or even in the context of symptoms of mast activation that are more systemic.
that's great. And you've actually been involved in creating a symptom score for these MCAS patients, which looks at kind of the symptoms in different organisms. It seems like this would be a great tool to follow patients forward as much as diagnosis. What did you create it for, and how are you using it?
Yeah, thank you so much for asking me about that. So I just see a huge gap when it comes to like just what you said, tracking symptoms associated with mast cell activation and trying to get a sense, like a objective sense as to whether any of the therapies that we employ are making a difference. And so what I did in conjunction with Millie Kwan, who's also part of the center, and then fantastic research nurses, Sissy Emilio, Katie Holtz, we created this scorecard where we had basically a way for patients to describe how often they're dealing with symptoms, how bothersome they are, how severe they are. And what we tried to do is actually break it down into symptoms that are deemed quote unquote of diagnostic value by the AAAAI 2019 guidelines for mast cell activation. And then by patient demand, we also included a couple of additional organ systems, so like neuropsychiatric type symptoms, because brain fog is like a big one, joint pains, and then genital urinary symptoms also come up. And so we've created this scorecard where you can separate like the Quad AI 2019 based symptoms and then the other patient requested symptoms and get a sense, of what it is and then what it is after they've started a therapy. And you can see whether the score goes up or goes down. Now, there's a lot of caveats, and that is that it has not been validated outside of our center. We're trying to work on getting the initial drafts out there so that we can get it peer reviewed and get feedback and so forth. But because there's such a huge gap, I've gotten a lot of requests, like both within the state, like within the country, even internationally, because we submitted a couple of abstracts about the scorecard to Quad AI a few years ago. And so people are like, oh, is this scorecard available? Can we get access to it? So we definitely need to work on validating it, seeing if it's helpful beyond just our center, like if other practices that are managing patients with mass activation type symptoms find it useful as well.
It sounds like you have a lot of people that are clamoring to be involved in a confirmation cohort. So there you go.
Yes, that's the goal. That's the goal.
Yeah. And a lot of these patients come in restricting their diet in kind of pretty significant ways. What do you recommend in terms of? I know people come in with all sorts of ideas about histamine and foods and what they need to restrict, or what's your goal and how do you try to counsel them with diet?
Right. That's also a fantastic question. It's a tough one. So I really don't like restricting diet. And so I'm always upfront with patients that at the end of the day, like my goal is to give them a sense that they can eat more freely, that they have a chance to broaden their diet. And I would like to use different tools, whether it's the pharmaceutical tools or natural supplements or other complementary and alternative therapies, as a way to get them to be able to broaden their diet. I will say, if it's pediatrics, unless there is one specific or a couple of specific foods that very consistently seem to be triggers, whether they're IgE mediated or not, I'm very against diet restriction, because I feel like it impairs, getting the nutrition that you need to grow when you're a kid. If you're an adult, I'm much more lenient, because as long as you're not going through a nutritional deficiency, if you really strongly feel that maintaining a particular diet is how you're going to keep yourself stable, okay, fine. I will still always say, like, can we tweak something with your medication regimen so that you feel more comfortable broadening your diet? Because sometimes there's a mix, not only of foods that they've had bad experiences with, but also anxiety about introducing new foods into the diet. The other thing I'll do is work with nutrition, because they can be fantastic allies in working with the patient, taking the time to figure out what works with that patient's diet, what would they be willing to try. So I think getting help from our colleagues in nutrition is super helpful.
No, absolutely. I often tell patients that there's not, with the medications we're using, there's not enough histamine in foods to really go beyond that, and we really should be able to block it down. And that's often helpful, but
As well.
it can be
Yeah,
very
I mean,
difficult when someone comes in eating only a few foods to.
it's challenging, because I mean, there are these, you, like you said, people will say like low histamine, high histamine diet and so forth. And there are these biogenic amines. So, like, components in food that kind of look like histamine or have a similar structure to it. And so in that way, they may cause some of the same types of symptoms as histamine. I know there's this controversial diagnosis or of histamine, like diamine oxidase deficiency or histamine intolerance type symptoms. And I I might give some credence that there may be patients where their diamine oxidase enzyme, either they don't have enough of it or maybe it's not functioning appropriately. I recognize that there have been studies, and they were talked about recently, like I think last year at Quad AI, showing that it's not clear that histamine intolerance is how I guess how pathologic histamine intolerance really is. But that being said, there is this supplement called diamine oxidase, or DAO, which some patients will try and to add on and find that it can help, especially with food intolerances and GI type symptoms like diarrhea. It's expensive though, and again, not FDA approved. So that there's always that caveat, but I've had patients who've actually done pretty well with those types of supplements.
Do you think all patients with MCAS should have an EpiPen on hand?
Ooh, I think they should, because if they have confirmed MCAS, because we don't fully, it's difficult for us to predict if they're going to have a spontaneous mast cell activation flare that constitutes severe anaphylaxis, which is when you'd be using your EpiPen. And since we don't yet have the biomarkers to predict, whose flares are going to be severe, whose are going to be mild or moderate, I think that we have to prescribe an epinephrine auto-injector or nasal epinephrine to our patients.
Fair enough. And then there's been this association that's come up between long COVID, which we're still kind of developing an understanding of, and mast cell activation. Is there evidence to say that these two are connected?
So I haven't seen direct evidence, but I think there's a lot of biological plausibility as to why we might be seeing this connection. And it's funny that you bring this up, because our mast cell disorders program recently had a publication that just got accepted to Jackie in practice. So very excited about that. Where we were looking in IBM Market Scan database, just at diagnosis codes that are associated with mast cell disorders. And so there's this diagnosis code D89.40, which is mast cell activation unspecified. And so if you look at that diagnosis code across, like, from 2017 to 2022 is where we looked at it, compared to idiopathic mast cell activation syndrome or indolent systemic mastocytosis, or some of the other more defined mast cell activation disorder codes, it's like an eightfold increase, whereas all the other ones, they're increasing a little, but just not at that same rate. So what it tells me is that over the course of the COVID pandemic, there was an increasing number of healthcare providers and patients who were worried that they were dealing with symptoms of mast cell activation. And there may be a signal that mast cells have a receptor that can actually that allows the SARS-CoV-2 virus to actually enter the mast cell. And we know that mast cells are involved in the innate immune response. Like, they're important for antiviral immune responses. So it may be with the COVID infection, having the virus did something to change the set point of the mast cell, so that maybe there's a lower threshold for spontaneous mast activation even after the virus has been cleared. And maybe that's why we're seeing this kind of signal. And I agree, specifically more with hives and swelling. Like, I've definitely seen this outbreak of chronic urticaria angioedema that we're used to seeing as like a post-viral response. But at least within my clinic, and again, there's a referral bias, I also see patients where it goes beyond the skin and it's involving the GI tract and also development of asthma symptoms that they never used to have before. And they're getting these things happening simultaneously. So there's biological plausibility since mast cells are involved in antiviral responses. I haven't yet seen the full research on this, but it may be coming.
No, fair enough. I mean, the good news is that we are developing a better understanding of some of these things. And so hopefully in the next 5 years, we really will understand where there are connections, where there really isn't.
Right. I agree.
And then are there any other common misconceptions that you feel like are important to mention, or to myths that you want to bust, or things that you want to remind people to check?
Mhm. Also an awesome question. So I think the biggest thing for me is to clarify the symptoms that are primarily driven by mast cells, because I think that's where I do the most counseling when I'm seeing patients. Because I'll have patients coming in saying that they're chronic fatigue or symptoms that sound more like dysautonomia type symptoms or constipation, that these are mast cell activation symptoms. So I always want to clarify that patients that are dealing with symptoms of mast activation can have a lot of comorbid conditions, and that the comorbid conditions may be driving a lot of those other symptoms. So I think it's just being really clear about the symptoms right now that we're really clear are of diagnostic value for mast activation, because there's the highest plausibility that they're being driven by mast cell mediators, and versus symptoms that people may experience alongside of that because they've got other things going on, or maybe they feel like they flare up when they're also having the more classic or conventional mast activation symptoms. So just to put that out there, that not every symptom is necessarily driven by mast cell activation.
Yes. No, people start ascribing everything to it.
Everything, exactly.
Well, thank you so much for taking the time to chat with us today. I think know that I learned so much about mast cell activation. I hope everyone else learned about mast cell activation as well. Is there a good place that you would like to point people for information if they have further questions?
Yeah, so the mast cell diseases, so TMS, they have a lot of fantastic resources available to patients. So I think that's one of the first places that I go.
We can link to it in the show notes. So we can definitely
Okay,
put
yeah,
out some resources for people who really want to go and kind of dig deeper.
okay.
Well, thank you so much.
Yeah, thank you for having me. It was a lot of fun.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at their website. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to rate and subscribe through wherever you download your podcast. Thank you again for listening.